very warm welcome to everyone who's listening now, and a warm welcome to Dr. Guido Urbano. Guido, he's a PhD student at the moment in neuroscience at the University of Turin and also a medical doctor, an adult neurologist, and he works at the ERN Neuromuscular Diseases Center and the Neuromuscular Unit at the Department of Neurosciences, University of Turin. Rita Levi Montalcini, I hope the expression is right in Italian.
Perfect.
And Guido works with Tiziana Mongini and the group. And Guido is an active member, a very active member, I have to say, luckily, of the Mitochondrial Working Group of the ERN EURO-NMD. And so he's majorly interested in mitochondrial diseases, but also in myotonic dystrophies, SMA, motor neuron diseases, and myasthenia gravis patients. So Guido will today hold a lecture on cognitive and psychiatric issues in primary mitochondrial diseases. And as most of you very well know, these CNS symptoms are very frequent in a lot of mitochondrial disorders. However, they are still hugely under-recognized, almost neglected, I have to say. So I'm very much looking forward to your lecture, Guido.
Okay, thank you very much, Cornelia, for the introduction. Yes, I agree with you. I think that your introduction might be also a conclusion of this work, but we'll see at the end of the paper of the presentation. So my topic today will be cognitive and psychiatric issues in primary mitochondrial diseases. I have no disclosures or conflict of interest to declare. And the speech will be organized into different sections. So there will be a brief introduction on primary mitochondrial disorders. Then I will provide some overviews on cognitive issues and psychiatric issues. I will present a clinical case that might be illustrative of the previous information. And finally, I will conclude with take-home messages and future directions. So we see that the schedule is pretty busy, but we have time, about 45-50 minutes, so we don't have to rush about that. So primary mitochondrial disorders are genetically determined diseases that are caused by defects in mitochondrial oxidative phosphorylation. They lead to an impairment of the production of cellular energy, ATP, that predominantly impact organs with high metabolic demands. These conditions are characterized by an extremely high clinical and genetic heterogeneity. To show and to have an idea of the extreme heterogeneity, we have to consider that we can have mitochondrial DNA mutations that can be maternally inherited or sporadic, and they can be both homoplasmic or heteroplasmic with a possible threshold effect on different organs. But at the same time, we can have nuclear DNA mutations with a Mendelian inheritance, both dominant and recessive or de novo. And as for the clinical presentation, we can have both multisystemic disorders. For example, maybe the most well-known is the MILAS, or single organ involvement disorders like the PIO. And they can present both in the adult age or as pediatric conditions. Actually, the heterogeneity is one of the most complex key points of the diagnosis of these disorders. So every time we suspect a diagnosis of mitochondrial disorder, we have to take into account clinical history, family history, laboratory and instrumental testing, and a comprehensive clinical examination that include not only neurological assessments, but also the collection of multisystemic data. So this leads to a suspicion of a primary mitochondrial disorder, and then we have to deepen the diagnosis with genetic and or histological testing. And to reach a diagnosis of PND, to start a multisystemic management Unfortunately, we don't have many disease-modifying treatment for mitochondrial disorders, but there are some exceptions. So, for example, the Leber hereditary optic neuropathy or the TK2 deficiency-related disorders are currently under investigation, and there are already treatments for them. So this slide represents the extreme multi-systemic nature of mitochondrial disorders. But as we've already said in the previous slides, the organs that are more affected are the ones that consume more energy. So muscle with muscle weakness, fatigue, exercise intolerance, but also nervous system, both CNS and peripheral nervous system. And some manifestation of the CNS and PNS involvement are stroke-like episode, ataxia, Parkinsonism, epilepsy, neuropathy, hypoacusia, neurodevelopmental delay, and cognitive symptoms. Even if we're not strictly talking about CNS disorders, we can include psychiatric symptoms in this group. And we have patient care standards for primary mitochondrial disorders. This is a very well-known paper, and actually it states how to investigate and how to care all the possible involvement in PMDs. And we have a part on CNS, so reading the recommendation, every patient with mitochondrial disease should be tested for neuropsychological and cognitive screening. In case of developmental disability or psychiatric symptoms, they should be referred to a specialist. That in case of changes of the cognitive or neurodevelopmental developmental regressions, it's important to guarantee to the patients a full assessment for potential treatment conditions, so under repeating neuroimaging or neurophysiological data exams. So after the first part of the introduction, I will focus on cognitive issues in PMDs. And I made this division to stress the presence of direct cognitive affections that is due to primary network alteration and structural brain changes, but also the presence of indirect cognitive affections that are other factors that might be part of the primary mitochondrial disorder, but they can be also responsible for cognitive alterations in non-mitochondrial disorders. So they can be a possible confounding factor. One premise is that it's extremely difficult to disentangle these two components, but we'll try to analyze each of them one by one. So among the direct factor, we encounter mitochondrial dysfunction alterations. We know that from in vivo studies that there are alterations in neuronal energy production and functioning. There's an increase reactive oxygen species production, a reduction of the overall number of mitochondria and reduced synaptic density, a delayed neuronal maturation, and alteration in neural dendritic morphology and remodeling. And we have a disruption in the synchrony and in network activity. Besides, we have brain structural changes that are among which the most common and most reported are cerebral and cerebellar atrophy, white matter abnormalities, gray matter involvement, basal ganglia calcification, and optic nerve atrophy. We have stroke-like episodes and stroke-like lesions that actually are in the middle between direct and indirect factors, because they are part of the disorders, but they can determine neurological changes as residual effects of their present. So stroke-like episodes are ictal episodes presenting with neurological alterations without evidence of thromboembolic changes. They have a characteristic neurological appearance. They are variegated for their neurological presentation. They can present as focal deficits, neuropsychiatric changes, encephalopathy, higher order cognitive functional alterations. There can be seizures focal with or without secondary generalization or status epilepticus. There's no one treatment to reverse them, but it's important to provide to the patient multidisciplinary management, observation, because it's possible to obtain a complete or partial recovery. It's very variable. Among the indirect, we put epilepsy because, of course, we know that it's part of the PMDs, but there are many evidence that even in not mitochondrial patients, epilepsy has a correlation, especially in cases with recurrent seizures, with recurrent and chronic seizures with a progressive cortical thinning. The changes in the brain are most pronounced in poorly controlled chronic and recurrent seizures, and they accelerate the process of brain aging. And we can see that the underlying mechanisms are not that different from the ones that we have described already as direct in primary mitochondrial dysfunction. Other indirect components can be the sensory deficits. Of course, we know that even in this case, just like epilepsy, they are they are already part of some mitochondrial symptoms, but even in patients without a mitochondrial symptom, mitochondrial disorder, hearing loss, visual deficits are associated with a higher risk of cognitive decline, and this is even more evident in case of combined sensory deficits, with hearing loss being the strongest contributor. Other factors are aging, education and cognitive reserve, cerebrovascular accident on a vascular genesis, multisystemic disorders, head trauma and falls, drugs, psychiatric comorbidities, and diabetes. So as we can see, there are many implications, and the correlations can be very difficult to assess singularly in this patient. But the neuropsychological and cognitive team in primary mitochondrial disorders has not been neglected throughout the years. We can see that there were different papers, even from the beginning of this century, talking about neuropsychological and radiological follow-up studies and correlations with clinical severity. However, the current literature evidence is very fragmented and difficult to access, and is mainly composed of case reports and case series, generally with small sample size. Besides, we have to consider that the patients included in the studies were diagnosed with different diagnostic criteria and inclusion criteria according to the time of publication and the availability of diagnostic means. And there's no systematic and standardized neuropsychological testing, nor robust longitudinal follow-up studies. So the works and information that I will present in the next slides are mainly based on these two review articles that are by Moore 2019 and by Klein in 2020, in which they resume the findings that have been collected throughout the years. So first of all, there were works in patients with A3243G mutation that compared MILAS symptomatic patients with carrier relatives and healthy controls, and they showed that global function through a global function screening that the global functioning is reducing MILAS patients. The findings on intelligence are mixed. in general, there are lower scores, but other studies show that there are some data within the normal ranges, even if closer to the lower limit. And specific intelligence profile data show higher verbal and performance IQ, whereas other reported better functioning of the perceptual reasoning index compared to the processing speed index. Talking about specific domains, I won't go too deep, but in general, we can say that primary mitochondrial patient performed worse than control or performed worse than healthy control on many tasks and subdomains. Another group of works focus on the correlations with disease manifestation and severity. The first one was Kaufman that found a correlation between worse neuropsychological results and MRS ventricular lactate. Then other works underlined how there was a correlation between longer disease duration and disability with poorer cognitive performance across many cognitive measures. But a more recent work by Krava in 2019 showed that there was an association between a higher score in NIMDAS scores and higher MRI lesions load with attention, verbal memory, and executive functioning tests. Moreover, it also showed that there was a correlation between the topographical localization of stroke-like lesions with this test, in particular those affecting the temporal and parietal lobe. I will present some cohorts of patients with a defined syndrome. So this was a work that was published in 2020 in which the authors analyzed patients with a CPO, genetically 4 had a single mtDNA mutation, while 4 had a nuclear PO. But they observed that the cognitive impairments were observed in global conditions, assessed through the MoCA test, executive function, and language. And interestingly, the deficit is correlated with the severity of the mitochondrial symptom and disease duration, but not with severity of the ophthalmoparesis. And this is very interesting because some tests might be influenced by the visual ability of the patient, but maybe there's there are other underlying mechanisms. And this study is in line with a previous one in 2003 by Bosbach, in which were analyzed patients with PO and Cursor syndrome, and they found that executive function were the most impaired. I report here a recent review published in 2024, considering 8H2-4TG patients, in which the authors analyzed the presence of neurological manifestations, and they found that cognitive impairment was the second most frequent neurological impairment after sensory neural hearing impairment. A recent paper from Winquist in July 2025 compared a group of 45 8H4TG patients with 45 matched controls and 17 relatives, and it showed that patients performed significantly worse than control in all neuropsychological domains, with executive functions being the most affected and verbal memory function being the least affected. They found that cognitive impairment in 16 patients with a predominance of male and a higher percentage of patients with previous stroke-like episode and a higher imputed Th2/4 heteroplasmy. Moreover, they find an association with sensory neural hearing impairment, diabetes, and neuropathy. so that we can return to the indirect factors that we have talked about before, that I presented before. The diagnosis of a major neurocognitive disorder was reached only 6 patients, and this is a little different from the expected data from literature, but might be influenced by the presence of a lower number of fully melas phenotype. So the last works that I will present in this part are those that consider a longitudinal assessment. The first one is by Kaufman, that considered patient with 3243 mutated genotype, and he analyzed that this patient presented a neuropsychological decline assessed through a neuropsychological global score that was an association of different neuropsychological tests throughout the years, considering a 4-year follow-up. However, the number of the patients involved is reduced throughout the years, and there's this bias. And another work by Moore in 2019, in which analyzing patients with 3243 and 8344 related mitochondrial diseases, they found that it's important to correct the cognitive results, considering the primorbid cognitive difficulties, because those patients are those that will perform worse than the others, that the decline can be present, but there are slow changes in cognitive domains tested at baseline 6 months and 18 months, and that there was a significant negative relationship between disease severity assessed through the NIMBDA scores and several measures of cognition. So the key point are of this cognitive part of my speech are the cognitive impairment is frequently reported in PMT. There's an overall global impairment throughout the that emerge from the literature data, but certain domains seems to be more affected than others. That there seems to be a relationship between cognitive deficits and disease severity, but the association with markers of disease progression, genotype-phenotype correlations remains unclear, and that systematic cognitive testing and detailed phenotyping are lacking, largely due to the extreme heterogeneity of PMD and the variability of the assessment tools. So, getting back to one of the first slides, and now we will move on to the next point, so the psychiatric issues. Even in this case, literature, there are multiple papers in literature that report psychiatric involvement in primary mitochondrial disorder affected patients. But it's also true that there are many papers that look for mitochondrial dysfunction as a pathogenic mechanism behind psychiatric morbidity, in particular schizophrenia or mood disorders. And there's a very wide literature on that. So they can purely there are some common shared mechanism that that play a role in both senses. The current the literature is mainly composed of case reports or case series. The first one that I would like to present is the one by Fatal, in which in his cohort of 19 cases, he found that major depressive disorder and psychosis were the most common psychiatric comorbidities, and that these symptoms may precede the diagnosis, so that the psychiatric symptoms could be considered as red flags in primary mitochondrial disorders. The same authors describe, in line with the previous result, describe a cohort of 36 patients with mitochondrial cytopathies observing an higher prevalence of major depressive disorder, bipolar disorder, and panic disorder. And comparing with other patients, they show that the patient with psychiatric comorbidities had more hospital admission, more concomitant medical condition, and a lower quality of life. The same work that I've already talked about in the beginning of talking about cognitive results show that in a cohort of 3243 patients, the fully symptomatic MERAS patient had a higher prevalence of psychiatric symptoms. Other findings confirmed the prevalence of mood disorders, in particular major depressive disorder, followed by psychosis. Interestingly, Anglin described that over a 10-year follow-up of this patient, they obtain psychiatric stability with no or minimal psychotropic medication plus mitochondrial supplements. So the refractory concept of psychiatric condition in primary mitochondrial disorders was discussed. And another important work was by Mancuso that showed that in Mancuso and others that in 2013 showed that there was a higher prevalence in 24 PMD patients than in the Italian reference population, about 60% versus 25%, and that the most representative psychiatric symptoms were depressive episodes, panic disorders, agoraphobia, and general anxieties. There were no difference were found per disease severity or progression. Another important topic concerning psychiatric issues are treatment options. Of course, is something that we are often involved into, but luckily we have an international Delphi-based consensus on the safety of drug use in patients with primary mitochondrial diseases. And I report here the section about neuroleptic drugs, in which we can see that there's no contraindication and there's no medication that are contraindicated in primary mitochondrial disorders. I report also the section about anti-epileptic drugs, in which we have just to underline that valproic acid should be avoided only in POLG patients, but in non-POLG patients with mitochondrial disease without liver disease, valproic acid could be used to manage refractory epilepsy and refractory mood disorder. So maybe it can be another tool for our patient. Of course, it's important to respect the good clinical practices and that clinical monitoring of these patients should be implemented, especially during their first days. So through both neurological examination and laboratory markers. But we have data on safety, but we don't have complete and full data on the effectiveness in real world settings. So it will be important to collect data. So the key points of this section is that mitochondrial dysfunction has been already investigated in the physiology and pathophysiology of psychiatric disorders and vice versa. But in general, the most represented psychiatric comorbidities are major depressive disorders and psychosis. We don't have an exact prevalence data, and probably we underestimate them. Psychiatric symptoms may precede the diagnosis for many years, but effectiveness data are still lacking in current literature. Actually, I'm an adult neurology, but I would like just to present to do a short digression on pediatric cognitive and psychiatric involvement. Even in this case, we know that there are some common problems shared with adult population. So we're mainly talking about small cohorts. The main literature findings are case reports or case series. the patient included had different diagnostic criteria, and the inclusion of patients and patients were included even with a possible and probable mitochondrial disease. There's, of course, an high genotypic and phenotypic variability, but we have also to consider that the neuropsychological testing differs according to age and neurodevelopmental degree. So the main finding that I would like to report actually show that there seems to be a high prevalence of depressive behaviors independent on clinical severity score and muscle involvement. That cohorts of patients with infantile conditions and mitochondrial conditions like Lee syndrome, Miller, or other non-specific MD shows significant developmental delay and behavior changes that were more evident in cases of brain structural changes and intractable epilepsy. And this study by Iom and Lee showed that even for parents, there was a higher level of parental stress and higher maternal depression scores that should be considered in the complexity evaluation of these conditions. So not to forget the caregivers burden. The data about epilepsy are confirmed even in other studies in which the patient with seizures, especially intractable or uncontrolled, and those with an early onset of disease had a worse cognitive phenotype compared with those without seizures and later disease onset. And in general, from this recent review, it's reporting a high incidence of cognitive and mental health impairment with IQ ranging from very low to above average, and a frequent association to poorer quality of life and behavioral problems, especially attention and depressed behavior. So now I would like to present an illustrative case that may resume most of the data that I already presented, and that can be useful to comprehend the complexity of this patient in a real world setting. So my case will be focused on David. That is a man born in the 80s with an education of 10 years. He had a diagnosis of Miller syndrome with 83240G mutation in 2013 after the first stroke-like episode. And these stroke-like episodes leave some lesions in the bilateral temporal and left occipital cortex with residual moderate mixed aphasia and hemianopsia. The patient suffered from epilepsy with generalized tonic-clonic seizures treated with good control with the levetiracetam. He experienced severe progressive bilateral hearing impairment and progressive vision loss. He had a diagnosis of avoidant personality, and his family setting was composed of an affected sister with a lower heteroplasmy level and a milder phenotype, an elderly father that was the primary caregiver, and a mother that didn't come to our attention because she died before the presentation in David. David had a very bad relationship with the hospitals because in 2019 he was hospitalized for a CRTD placement in severe heart failure and a Wolff Parkinson-White syndrome. But 2 years after, he had an infection, so the cardiologists were forced to remove the device. And this worsened the pre-existing avoidant attitude towards healthcare professional and medical treatment. And these events determined further withdrawal from social interactions. In 2024, his father was hospitalized, and he developed an apparently unjustified verbal aggressive behaviors towards a domestic worker. Luckily, there were no juridic consequences, but a few days later, David explained that he had behaved in that way because of his poor vision and severe hearing impairment. And in that situation, he believed that the person that entered the house was a thief trying to harm him. After his father's death, the situation complicated because his sister became his principal caregiver and legal guardian, but she realized she couldn't handle the situation on her own. She looked for a siphoning of social support through a nursing assistant, but David opposed having anyone in his home, so he behaved aggressively towards him. The patient was then admitted to the hospital for a respite care stay and treatment of the psychiatric comorbidity. But during the hospitalization, the healthcare professional experienced difficulties in approaching and administering therapies because he refused them and acted in a hostile manner, needing sometimes some sedative therapy. Luckily, after our neurological evaluation, we found together with him that hearing and visual deficits were among the emerged as major problems. So we tried to communicate with him through written paper and a tablet after setting an appropriate brightness. And we obtained an enhanced compliance and collaboration of the patient towards a healthcare professional. The patient restarted taking his medications, and we obtained through a conjoint evaluation with a psychiatrist the introduction of a low dose a low dose introduction of an atypical antipsychotic drug, aripiprazole, with the benefit on his behavior and with the possibility to find a place in a residential facility for him. So this complicated case actually raised some question raised some question. Of course, we know that there were problems inside David's mind that were related to previous stroke-like episodes, epilepsy, sensory deficits, auditive and visual, avoidant personality, but also future anxiety for his future and reactive depressions. And we can see that we have both the direct and the indirect components inside David's mind, but we have to we can't neglect the presence of an outside David's mind component. So there's an overall scarce knowledge of primary mitochondrial disorders. Caregivers' burden and difficult management are sometimes forgotten, and there's still insufficient social structure and facilities. So my question to the audience, but the question that I posed to myself was, how can we properly evaluate this kind of patient, both from a cognitive and psychiatric perspective? How can we separate the direct and indirect components and to attribute the issues to different elements? And how can we manage and take these issues? And are the outside problems really easier than the inside ones? So actually, I don't have an answer, a definitive answer for this. So I will be open to your comments and suggestions at the end. But let's go to the final part of this presentation. So the take-home messages and future directions. So as a final message, we can say that the current literature evidence is still insufficient to assess and quantify cognitive and psychiatric involvement in TMDs. So we need to collect robust data through detailed phenotyping and genotyping. It's important to share common neuropsychological tools and CNS involvement assessment protocols, because we have to identify potential effective measures and endpoints. It's important in this field to underline how cognitive and psychiatric, as well as the patient-reported outcome measures, are already part of the outcome measures of the clinical trials. So we really need to advance in this field. Talking about the neuropsychological and psychiatric batteries, it's important to screen patients from a cognitive and psychiatric perspective, and to share a common battery prior to conduct any further and deeper investigation. We have to consider the level of patient compliance and collaboration when thinking about the test that we would like to administer to the patient. And at the same time, we have to consider also the sensory deficits of patients. So we have to design tools or utilize or use tools in which it is possible to foresee a visual impairment or hearing impairment. Here I report, for example, the MoCA blind version that is already validated for blind people. And we know that, we also know that there's an effort to develop motor-free tests for patients with neuromuscular disorders. So we need to use adaptive versions, especially if they're validated. And we have to refer patients to psychiatrists when potential symptoms are identified. And in this case, we have to fight also against the stigma of a psychiatric evaluation, because we have to have the right time and to have an appropriate time to explain to the patient that the psychiatric evaluation is important for assessing the problem and to find a solution, so that he can find benefit from an appropriate care. As for the future, it's important to associate cognitive and psychiatric findings to genotype and the severity of phenotype. It's important to promote the integration of structure and functional neuroimaging and neuropsychological tests, along with the research of laboratory markers of CNS involvement. It's important to gather data on psychiatric medication use, safety, and effectiveness in real world in PMDs. And we should start thinking about providing support in cognitive rehabilitation and social intervention for these patients and for their families. But last but not least, the final message is that it's extremely important to collect data in registries for assessing on the patients and to have a longitudinal systematic assessment. We all know that maybe I'm directly involved, so I can speak on my personal experience. Of course, it requires time, but there's no other way. This is the only way which we can make advancement for understanding, for comprehending these disorders, and for giving a real benefit to the patient. So this was my last slide. I would like to thank you for your attention, and I'm really open to questions and happy to receive questions and answers, maybe, or comments if you have some. Thank you.
Thank you very much, Guido. It was a fantastic talk, very comprehensive, complicated topic, I think. Thanks a lot. So the lecture is open for discussion. Are there any questions? You can use the chat function or Q&A function of Zoom, or you can just log in. Any comments, any questions from the audience? So not yet. Let me start, please, Guido. I'm very interested in let's say personality traits. Did you find something in the literature? I mean, not just the typical psychiatric evaluation, standardized evaluation, or neuropsychologic test batteries. I mean personality traits. You know, like there are some special questionnaires and so on. Did you find something in the literature on that?
Yeah, actually, there were some case reports of patients with different symptoms that describe personality trait disorders, but they, in particular, I think that the most represented were the avoidant personality trait. That was the same that we presented, that I presented in my patient. I think
exactly.
that in general, that part of the psychiatric, I would say psychiatric evaluation, is really complicated to assess in
Yes.
this patient because I think that it requires time, and as I try to show during this lecture, sometimes it's difficult to keep the attention and the compliance of the patient throughout a long assessment. So I think that this data could be really, really useful. Actually, I think that in our clinical experiences, we all know that there's something underlying. We all know that the personality traits are more frequent, and
Yes.
I can bet that they are underrepresented. I can bet on that, but I don't have numbers, so I think that it's important to collect them. But at the same time, I have to. My reflection is that this could be one of the most difficult data to collect because it's difficult to have a comprehensive psychiatric evaluation on that.
Yeah, thank you very much. Yeah, that's our impression too. So we started that such a project really years, decades, I have to say ago, but we never finished because it was so difficult with the compliance of the patients because these are very, let's say, comprehensive questionnaires, very sensitive questions, hundreds of questions, and it's very complicated, to finish these projects.
I think that there are many factors that might interfere. So it's because I think that probably is not the first data that I will include in these evaluations. It's something that will come later, probably. I hope that it will come later.
Yes, and one should do that in a systematic way, but it's not so easy. You need higher patient numbers. And yes, I think your case was really brilliant because it was so typical, so characteristic. We all know these Milas cases who it's quite representative, I think, for this disease and its in the Milas phenotype form. Yeah.
Yeah, I think that in Milas especially this complexity in the
Real
I'm talking,
Milas with the stroke-like episode.
I'm talking about the adult field, but Milas can be representative of the complexity and the different interactions between factors that can be direct and indirect. So it all is difficult to disentangle.
Yeah, thanks a lot. So any further questions from the audience? Elizabeth, are there any questions you see?
I cannot see any questions. Dear Jens.
And stop sharing mine as you want.
Yeah, okay. And I just want to advertise for the patient registries. Italy's included in the Genomit too, you know that, with the Mito registry, the German, and it's now we can, let's say, somehow integrate the Italian registry, and there are at least some really minor parts on cognition and psychiatric issues in this questionnaires that are included in the registry. And now we will present some data on the WMS and on the German neurology Congress this year on the first data analysis, and we analyzed about 700 to 800 patients with this. Very, it's not much included in the registry, but very, very. I think that's very good to use this patient registry wherever possible.
Yes, I think that one is the only way possible to have data, and I think that the setting of this registry is particularly interesting because even for the clinicians or for the data manager, it's important to insert a specific HPO code so that we as clinicians, it's important that we start talking the same language. So we have to identify the same things with the same code, and that's the only way to obtain strong
Yes.
data. And
Yeah.
actually, that was my last slide, but maybe
Yeah.
one of the most important one, because I think that we can go only through that way. We don't have other options.
Yes. Yeah, I mean, it was you showed that we have case reports, we have very, very small case series. It's quite heterogeneous. The diseases are heterogeneous, cognitive function is heterogeneous, different disease phenotypes, different genetic backgrounds. So it's really complicated. So I think that's the only way to collect more and more data in a standardized way. You know, an international way, and the ERN is working on that. I mean, that's inter-ERN and ERN. Yeah. So, any questions? I think, Elizabeth, when there are no further questions from the audience, I think we can finish here.
Oh, there is no further question.
Yeah. Okay. Yeah, then thanks again, Guido. It was fantastic. So we can this lecture is open for streaming, Elizabeth.
Yeah, it will be
Yeah.
on replay this week on YouTube and the website.
Ah, okay.
Yeah.
Okay. So it will be available in the end of this week, or it's
Yeah, tomorrow actually.
okay, very good. Thank you. Thanks a lot. Okay. Yeah, thanks,
Thank you.
Guido.
Thank you very
Thank you.
much, Guido. Thank you,
And thank you very
Cornelia.
much to both you, Cornelia and Elizabeth, for the
Bye.
support, and
Of
to all the
course.
audience.
See
Bye.
you.
Thank
Thank
you.
you. Bye. See
Bye.
you.
Thanks.